What does the current treatment landscape look like in psoriasis and psoriatic arthritis? Can you go through the next slide, please? Again. Okay, so what we're dealing here is what are the therapeutic options available, some questions, and then the future perspectives. Next slide, please. Just to understand, the first thing I would like to know from you is, do you go through all the synthetic DMARDs before going to a biologic? Do you start with leflunomide, methotrexate for a appendicular psoriatic arthritis, not axial, or you go already to a biologic? I just can see Alice nodding that yes.
I mean, if you're focusing, are you focusing on specifically spinal disease? You're not going to use methotrexate. It doesn't work. You have to go on to a biologic that has been studied in at least ankylosing spondylitis, if not psoriatic arthritis itself. So that is a definite wrong answer on the test, so to speak. So if you're asking that specific question, if you're talking, are you talking about efficacy or only cost? If you're talking about efficacy, nobody would.
The whole package.
If you talk purely about efficacy in psoriatic arthritis, nobody would use only methotrexate, sulfasalazine, leflunomide, definitely not cyclosporin, azathioprine, Cellcept. You wouldn't use any of those as a first-line treatment based on evidence-based medicine. Okay, of course you would use a TNF blocker or IL-17 blocker. This is tempered by cost. So what is really the question?
Yeah, I mean, I think in terms of real access, we have to go through two conventional DMARDs before patients are eligible for treatment with biologics in the UK. And we have a proportion of patients who do okay. You know, I've got patients in my clinic who are on long-term methotrexate or leflunomide or similar who do very well on it. So it can work. But as Alice says, you know, there's plenty of studies out there looking at comparing conventional DMARDs with biologics in early PsA, and biologics are far superior. So if they were as cheap, then that's probably what we would use. I don't think that takes away from needing to use conventional DMARDs in an awful lot of healthcare settings. Even, you know, in quite affluent countries with good coverage, you usually have to try one conventional drug before access to biologics. So it's sort of pretty universal that most patients would try at least one conventional drug, and they can do very well. But yeah, if it was purely on efficacy and safety, then you would probably go straight to a targeted therapy of some variety. You know, it depends exactly what sort of disease they have, how bad their psoriasis is, whether they have inflammatory bowel disease, all those other things. So there's a lot about choosing a drug, which requires looking at the patient holistically to work out what's best for them.
Can I ask my ex-US colleagues, I think a relevant question, whether there's some studies on it now that certain TNF blockers are so inexpensive abroad? I mean, I hear that the yearly cost of a TNF blocker is down to $5,000 US a year.
It's less than that.
Less than that. Does that influence, I mean, does it make it easier for Laura Coates to write as first line a TNF blocker rather than going through some of the other stuff that we know doesn't work that well in most patients, and makes them sick to boot? I mean, has that had an effect? Has that actually increased access?
It has in some cases. So I think if they had come along that cheap to start with, it would have been a completely different setup. You know, there's this big divide between conventional drugs and biologic drugs and access rules. I can prescribe anybody methotrexate, leflunomide, sulfasalazine. Nobody cares. Nobody checks. But for biologics, everybody checks. And actually, but, you know, cheap biosimilars are not much different to injectable methotrexate in terms of cost. So there isn't such a big difference now, but I think we're stuck with the systems that got put in place when they were more expensive. and we're stuck with the restrictions that we have. Having said that, in the UK, we did get an expansion in terms of access, particularly for rheumatoid. So for psoriatic arthritis, they've always been available for patients with 3 tender and 3 swollen joints, which matches the trials and actually covers an awful lot of our patients. In rheumatoid, the requirement in the UK, which is worse than mainland Europe, was that you had to have a DAS score of 5.1 in rheumatoid arthritis, which is quite significant active disease. That's now been reduced so that we can use biologics in moderate DAS. And that was a change a couple of years ago, and a lot of that was due to the cost-benefit assessments. So it has improved access, but probably not as much as it should have done.
If you are planning to look at those guidelines again to see, or whatever, or the regulatory authorities, now that those really have come down in cost?
Well, so the EULAR guidelines from this year said 1 DMARD and then biologics, which, is pretty universal, I think, across, in terms of most people have to go through at least 1 drug unless there's a good reason why they can't take it. And for most of the drugs, their license is around having previously failed a conventional DMARD. At least in Europe, a lot of the licenses state that they should have had a conventional drug first. So there is an issue around licensing as well.
So what we're seeing here is that there is an ideal world where we just are driven by efficacy and safety, and a real world where access and the guidelines are demanding that we use systemic DMARDs. The next slide, please, that we will think about psoriasis. And in this case, I ask everybody to just see if there is something missing here, because I could miss something, obviously. And again, and I will ask everybody, in Brazil, in Latin America, we're driven by cost and access. I believe it is in all the world, but here especially. TNF alphas are the first line here due to access. If that was not the case, would you still start a patient that has only cutaneous psoriasis, independently of how bad it is, in a PASI beyond 10? Well, would you still start on anti-TNFs, or anti-TNFs are just should be regarded as for some special cases, especially when there is some kind of psoriatic arthritis involved? Ulrich.
Well, I would like to add to this list the fumarates that are.
Oh yeah.
That are used.
Sure, I always forget because we don't have it here yet.
Yeah, I know. Right. It's a European phenomenon. Well, this is a tricky question that you are asking, because, I mean, what we want to do is to change a strategy, and this strategy, and that's not only in Germany, as I'm aware, is save the best for last. So you start with a fumarate or methotrexate to treat plaque psoriasis, and then you wait for success, and then you step up the ladder maybe until you reach a high-priced drug, and then you stop at all. And that's what happens at several occasions here in Germany. And Craig Leonardi obviously named this the ladder of shame, which I really, really like. So we try to convince our doctors that the opposite, take the best for first, is probably the way to go for. And I mean, Laura may comment on that, and Alice as well, as the PsA experts here, that this nice statement of Dennis McGonigal, buy one, get one free, is probably very true in a preventive way of treating psoriasis. And in the guide study using guselkumab, we can see that the earlier you treat the disease, the better is the outcome, the more high is the proportion of super responding patients that later do not need any treatment to maintain their psoriasis in a cleared state. So I think we totally need to shift from the common save the best for last to take the best for first and at the earliest time point. Of course, this is a paradigm that is highly, let's say, expensive in the beginning, but it will be more cheap in the running years because the following damages that we are treating thereafter are definitely much more cost expensive than treating earlier and being preventive. But prevention, of course, in the end is always the best and the cheapest solution. So this is what we are doing and we're trying to do to establish, and phototherapy has no longer the place it had years ago.
I think that Ulrich mentioned the point that I wasn't to make is that we need to give the most efficacious biologic first. But is there a rationale for choosing that? Is it just pivotal trials? What are the best biologic to do? Should we choose the best biologic? Should we give a list of better to worst biologic as a guideline to dermatologists?
I don't think there's only one winner. I actually would disagree with the hypothesis. You know, for somebody with Crohn's disease, for example, you know, a TNF blocker may be the first choice to use. And psoriasis, for somebody with a malignancy, you know, a recent malignancy, acitretin may be a good choice. I mean, that they can't give them an immunosuppressant, you know, let's say a lymphoma or something like that. I mean, so it really depends on the patient. I think dermatologists are smart enough to look at the data and make a decision for themselves. I mean, I don't think we have to say you have to pick biologic 1 over biologic 2 or 3 or 4. I mean, patients are not all the same. Of course, we know that the financial deals between the payer and whoever the payer is and the companies are not the same. And so I think that to force that there's only one winner or 1 or 2 or 3 winners and everything else is a loser is selling the dermatologist short, but it also puts the dermatologist potentially at legal risk. So, and I don't think
it's a case-by-case scenario.
Yes.
Paolo.
Yes, very shortly. In Italy, very shortly. In Italy, the government choose for me in a way that for me, the first biologic is adalimumab biosimilar. By definition, I cannot avoid this. And in case of failure, contraindication, inefficacy, whatever, I can go to another, let's say, more potent biologic.
And future perspectives, is there a role for Ajax and psoriasis? What do you think, everybody?
I'll give you a scenario where they are useful. You have a psoriatic patient who, let's say, on an IL-17 or 23 blocker, all of a sudden develops spongiotic dermatitis. All of us have those kind of patients.
That's the one I think about, yeah.
A JAK inhibitor may be the best. I mean, for that, assuming it's safe enough for that patient. So that's an easy answer for that quick one. That's an easy one. Another scenario is a psoriasis patient with Crohn's disease. Upadacitinib is approved for Crohn's disease and works quite well. That's another scenario. Again, I think we should be very careful about, you know, playing the ultimate judge for dermatologists because patients do come in different flavors. So do I think that they are the obvious first choice for all psoriasis? No. But I'm glad I have them for certain cases.
Okay, Paolo?
Yes, I agree with Alice. Moreover, there are some patients that since the beginning, they have psoriasis and eczema. In some way is an overlap. Let's say an overlap.
Right.
And you don't know if it is eczema that is psoriatiform or psoriasis that is eczematiform. But anyway, in these cases, JAK inhibitor could play an important role.
There was an article in the JID this year that when they looked at the patients who developed this spongiatic dermatitis on a highly effective psoriasis biologic, it turned out they had gene sequences that were already eczema related. So they were pre-programmed to have both in a certain sense.
Yeah, there's an overlap for sure.